separate and unique issues associated with those classes of physicians. It's been very, very challenging for the author and his staff and the stakeholders to get to this point with this class of physicians. This does represent the largest class of balanced billing. If we are successful here, we think, as Mr. Panish from Mr. Parada's office indicated, that this then could be a framework in the future for moving to add others in. But I think at this point that would be a bridge too far.
Okay, my second question was, again, one that was raised in the analysis, and that had to do with the impact on ER physician contracting. And just the question being, what will the impact of this bill have on the willingness of ER physicians to enter into contracts with health plans?
Well, let me let the ER physicians answer that question,
okay,
if I may.
So, Doctor, you may conclude with the answer of this question.
This actually is right where I was going. Currently, my group, which serves about 55 hospitals in California, has contracts with just about every health plan in the state and most of the medical groups and IPAs that have network relationships with our hospitals. The average health plan contract that we have pays us about $250 a claim. The average contract that we have with medical groups and IPAs pays about $160 per claim. Where that extra $90 goes, I don't know, but I presume that the health plans put half of it in their pocket and the medical groups put the other half in their pocket. But the consequence of being paid, for example, in an interim payment rate that was predicated on contracted rates, which is what we understand CAPCHE wants to do, would result in a payment somewhere between $200 or $210 or maybe $190 a patient, and that would be, maybe $100 million in direct losses to non-contract providers. Plus, since our contracted rates are predicated on what we can get, what we can collect as non-contracted providers, a low interim payment rate would cause the health plans to probably cancel all the contracts that we have that are above the interim payment rate. And like I said, every single health plan contract that my group now has with, Health Net and Aetna and Blue Cross and Blue Shield and all the others is above what this is currently above the it's about 200. I think the lowest is $210 a patient, effectively, and that would mean we would end up, and that's a discounted rate from what we get when we're not contracted. So basically, the health plans would cancel every contract that we have, and most of the RBOs would reduce our contract rates concomitantly. So this impact of a low interim payment standard would push down not only on what we collect as non-contracted providers, which is about half our claims, but on what we get when we contract or when we try to negotiate contracts, which is the other half. And then lastly, I think it's really important to point out that we have tried to create an interim payment standard that brings us close to what our current revenue neutral situation, current revenues would be. If we have to dispute every single claim because the interim payment rate is substantially lower than that, it will mean disputing upwards of 2 million claims a year. There's no way that an independent dispute resolution program could ever handle anything close to that. And so we'd end up getting screwed by it.
Can I provide a slightly shorter answer? Yeah. I believe it's the author's office's view that it depends on where you set the interim payment, as the witness indicated. And the witness is essentially anticipating some testimony I think we're going to hear in a moment that would ask you to set that payment, in our view, very, very low, which could have the adverse effects on contracting that the witness has talked about. However, if you set the payment at a reasonable level and you ban balance billing, we believe that there will not be an adverse impact on contracting and, in fact, a positive impact on contracting, because if you can't balance bill anymore and you're being paid reasonably but you have to go through a dispute resolution process, the disincentive to contract begins to drop away, and we believe more will enter into contracts. Again, though, it depends on where you put the price point for the interim standard. We think we've got a good starting price point. We recognize that we've got to we need some adjustments on that to probably better reflect actual revenues, which is something ER physicians have asked for. But we don't believe that there will be an adverse impact, as long as you set the interim payment correctly, that there'll be an adverse impact on contracting. That's the short answer.
Nakanishi?
I'm in a quandary on this bill. Rightfully so, the health plan and non-contract ER physician should make the deal. I don't think the government should be fixing prices. The second question I have, your point's well taken. Why do you want your price fixed at a lower cost than you're making right now? The other question I had was the comment by Senator Parada's person, or the question is, this is the beginning, you're going to fix prices for ERs, and you're going to fix prices for radiologists, anesthesiologists. Where will this lead to, fixing prices? So I'm in a quandary about this. So I'm going to, that's my comment.
No, I appreciate that, Mr. Nakanishi, but understand the context in which this bill is appearing before you. The administration has just promulgated regulations that ban balance billing across the board, and so so if your concern is with regard to the ability of ER physicians to get compensation, if the administration approach carries sway, they won't be able to balance bill at all. And so then they're left to basically litigate the issue out with the health plan. We don't think that's a good approach either in isolation. So what we're trying to do is essentially offer a compromise approach which bans balance billing and gets the patient out of the middle, but also sets a reimbursement level which is based on what's happening in the market. This is right now in the bill. It's the median of charges under Medi-Cal. Recognizing we've got to continue to work with the stakeholders to adjust that because there's some legitimate concerns about whether that's too low. But the author's office believes that that's a better approach than just totally intervening in the market and saying no more balance billing.
Thank you.
Yes, thank you for this opportunity. I just have a problem with the whole fee issue, and basically what we're doing is we're transferring this liability to the insurance companies, which then will transfer it to the insureds, and everybody's rates are going to go up. And so it seems to me that there ought to be other ways of approaching this if there's an issue with Medi-Cal in terms of Medi-Cal rates and they're not high enough. I think that's something we've got to take a look at. I think that's very difficult in the deficit year that we're struggling in right now. But it seems to me that there are always chronic problems at emergency rooms across the state, and that if there were other avenues for getting services that perhaps could be owned and operated by emergency physician groups in the way of clinics, that could be revenue raisers for that entity, and then those could help offset some of the losses that are occurring in the emergency rooms themselves. But clearly we know that if you've got an issue and you've got to go to an emergency room and you're sitting there for 6 or 8 hours, and there's been talk about loosening up regulation throughout the state of California for more clinics, that might be a possible option or approach to solving some of the revenue shortfalls that you're experiencing.
I think there may be some confusion, though. We're using the 50th percentile of Medi-Cal charges as a price referent, but we're not talking about patients who have Medi-Cal. These are patients who have insurance, but where the ER physician is not in contract with that plan. So these are insured patients, but there's not a contract, and as a result, these insured patients, not poor people under Medi-Cal, are receiving a bill from the ER physician for most, if not all, of the cost of the service, notwithstanding the fact that they have health insurance and they believe when they go to that ER room that they're covered. So what we're trying to address is that issue, and it's not designed to solve the other problem, which you appropriately allude to, which is the inadequacy of Medi-Cal reimbursements and the inadequate resources coming into ER rooms. It's designed to address the narrower but equally important issue of taking patients out of the middle of these disputes, but at the same time, in doing so, making sure that the physicians providing the services have an opportunity to receive compensation, an adequate compensation for the services that they are by law required to provide. They don't have any choice about the matter. You walk in, you're ill, you need services, they have to serve. And so that's what this is trying to accomplish.
Okay, thank you for clarifying that, but I'm still concerned because there's still a cost shift occurring that would go to the basic membership of any health plan, wouldn't it?
Let me try to have the witness answer that question.
The current model is that the healthcare plans save money by they do cost shift. They let the patient carry the balance bill. That, if you were to ask me for my view, which is obviously a little bit biased, currently the plans are abusing both the patient and us. They underpay us, and they're abusing the patient by asking the patient to pay the remainder. What we'd like to do is get a fair interim payment standard to take the patient out without resulting in a windfall for the plans, because the specialty just can't take another hit. So I think that 981 is a reasonable stab at this. This is a difficult problem that people have been working at. When you start tossing in the other specialties, it gets even harder. CalACEP is a little bit proud of its ability to work with the authors and others to try and go forward to get the patients out of the middle so we don't have